Right. So Dr. Matthew Fullen is an associate professor at Virginia Tech, where he teaches in the counselor education program. Dr. Fullen's research, teaching, and advocacy focus on the mental health needs of older adults, with an emphasis on addressing gaps in Medicare and mental health policy and developing programs to enhance resilience and wellness and prevent suicide among older adults. His perspectives on aging and mental health have been featured in the New York Times, Forbes Health, and Healthline. Dr. Fullen has collaborated on over $6 million in research grant funding to develop programs that support older adults' mental health, including sponsored work in both public and private entities. In recognition of his research and professional leadership related to Medicare advocacy, he has received the Virginia Tech Land Grant Scholar Award, as well as three national awards from the American Counseling Association. Dr. Fullen, we are honored to have you join us today. And at this point, the floor is yours.
Wonderful. Well, thank you all so much for joining. I'm excited to spend some time talking about kind of the latest developments around Medicare. And hopefully over the course of the next hour, you will leave with a better sense of where our profession is at and what the needs are among Medicare recipients. So without any further ado, let's dive in. We've got a lot of information that I'm hoping to get through today. The Medicare program, first established in 1965, and this is, of course, the federal health insurance program for people over the age of 65, as well as certain younger people who qualify based on disability status. There are currently over 68 million Americans covered by Medicare, which is just short of 20% of the American population, and estimates of about 1.3 million increase each year over the next decade, largely driven by age-related demographic shifts in the American population. One other note that we'll unpack a little bit is that the original Medicare Part B program later evolved into the addition of Medicare Advantage, also known as Part C. These operate as two distinct parts of the overarching Medicare program, and we're currently at a place where there's actually a little bit more people that are enrolled in Medicare Advantage as compared to the original Medicare Part B. And as I mentioned, we will unpack that and implications for that in more detail in a bit. If you kind of take a little bit of a walk down memory lane, 1965, when Medicare was established, this was really the US's best attempt at nationalized healthcare. There was clamoring and debate about just how to get to some sort of nationalized healthcare approach. And, advocates for more of a nationalized approach in debate with those who had concerns about it, ultimately compromised around doing something that could be federalized, but federalized for just a portion of the population, and older people ages 65 and up were kind of the initial test group for that. In 1972, eligibility was extended to younger Americans who qualify based on long-term disabilities or end-stage renal disease. Fast forward to the 1980s, and you see an expansion of mental health providers added to the program. Notably, clinical social workers become eligible to participate as Medicare mental health providers, and certain restrictions were removed from psychologists at that time. And then if you zero in on specific mental health advocacy around Medicare, over the course of the 2000s, organizations such as ACA, as well as the American Association for Marriage and Family Therapists and the National Board of Certified Counselors, alongside many other counseling and therapy professional organizations, begin to mobilize and advocate for the inclusion of licensed counselors and marriage and family therapists as Medicare recipients. But it took over 2 decades for that to bear fruit. And it wasn't until December of 2022 that Congress finally passed through a Consolidated Appropriations Act, otherwise known as an omnibus budget reconciliation bill, finally passed legislation that included several adjustments to Medicare, not the least of which was the addition of licensed counselors and MFTs as eligible providers. So just to draw a point on a couple of these things, it took nearly 20 plus years of advocacy and a gap of roughly 35 years between when clinical social workers were added and when licensed counselors and MFTs were added to this program. And there's, a long history of what was going on within that time frame. It is important to note here that changes to Medicare require, at least this particular provider level change requires an act of Congress. And so being able to have bipartisan support, agreement across the aisle that more mental health providers were needed was a critical part of this advocacy process, and also part of why it took so long for Congress to finally make that change. But that's where we are currently. We'll spend a little bit more time here shortly talking about what that new state of affairs is for counselors and MFTs working within Medicare. So this session is billed as 10 things that you need to know about Medicare. And so I'll do my best to sort of walk us through those 10 in a timely fashion. But because of the focus that ARCA has, I wanted to sort of kick things off with a discussion of the fact that approximately 15% of Medicare beneficiaries are younger than 65 and qualify based on long-term disability status. And that percentage ebbs and flows depending on enrollment. And so it's been anywhere between about 10% and 18% in recent years. I would imagine, based on some of the age demographic shifts that are happening nationally, that the percentage that qualify younger than 65 will go down a bit. And I'll show you here some of the other kind of snapshots around enrollment. So 68 million Americans currently. And if you take the absolute latest snapshot from the Center for Medicare and Medicaid Services, it's just a hair under 10% that are currently under age 65 and qualifying based on long-term disability. So again, that number does fluctuate year to year. But that's nearly 7 million Americans who rely on the Medicare program, not primarily due to their age, but due to having a long-term disability status that qualifies them for Social Security disability insurance. And from there, after a 24-month period, entry into Medicare eligibility as well. And this is a part of the Medicare population that is routinely under-acknowledged or overlooked. And so while, yes, 90% roughly of Medicare recipients do qualify based on age, it's critically important for providers, for advocacy groups, et cetera, to not lose sight of the nearly 7 million Americans who currently qualify based on long-term disability. And ultimately, my comments today will be as inclusive as possible of both of these Medicare populations. My research and clinical work does focus on aging, and so you'll see some additional references to that as well. But I hope that as we go forward today, you'll think about the way that Medicare enrollment status and some of the positive changes that have happened for the counseling profession really do have an impact both for older adults and for younger people that qualify based on disability. A couple of notes from the Kaiser Family Foundation comparing these two Medicare recipient subgroups. It is important to note that those under 65 tend to have higher degree of poverty and report more likely to report fair or poor physical and mental health. And so if we're just kind of doing a snapshot of those age 65 up compared to those under 65, some of those demographic differences do emerge. And similarly, if we can, excuse me here, I clicked on my slide and that wanted to take me to a link. So let me pull that right back up. But similarly, if we talk about comparing these two groups and we look at experiences with access to mental health care availability specifically, those under 65 are more likely to report some challenges when it comes to accessing mental health therapists and mental health professionals. They were also more likely to report experiences as only being fair or poor. Um, some of this, it'd be interesting to see KFF take another snapshot of this now that counselors and MFTs have entered the program. Much of this data precedes our ability to enroll as Medicare providers, which didn't kick in until January of 2024. But you do see here some disparities in terms of kind of customer satisfaction or beneficiary satisfaction related to finding mental health services specifically. Now, as promised, I want to go a little bit deeper into what exactly changed January 1, 2024, when the new Medicare law went into effect. And so, if we look at this sort of holistically, some interesting things to consider. So Dr. Meena Seshamani, who at the time was CMS Deputy Administrator, talks about the changes to Medicare as being some of the largest ever toward a Medicare that recognizes people with Medicare as whole persons, with their own families and unique life stories. And they close by saying, after all, people are more than the sum of their ailments and diagnoses. And so, having worked on this, having tracked this for a long time, I can say that within CMS, there was a lot of excitement about some of these changes, not only the addition of counselors, but also some of the other ways that mental health was receiving a more prominent profile within the Medicare program. And so starting January of 2024, the Mental Health Access Improvement Act, which was the language included in that end of year budget reconciliation bill, allows mental health counselors and marriage and family therapists to participate fully in the Medicare Part B program, as well as Medicare Advantage once they enroll, and it allows them to diagnose and treat older adults and people with qualifying disabilities who are covered by Medicare, as well as to serve individuals who rely on Medicare plus another form of health insurance, whether that's Medicaid, VA benefits, et cetera. And so this was really important because for the better part of 35 years leading up to this, anytime a Medicare recipient wanted to work with a counselor or a marriage and family therapist, we were hearing many reports of that either being turned away outright, or even if they were reliant on multiple forms of insurance. Maybe they had Medicaid and Medicare, or they had a private supplemental insurance in Medicare. The lack of recognition by Medicare would really become a major roadblock for services to be delivered. And so we did some research on this prior to the law change and saw that counselors were responding by providing sliding scale services or having to turn people away or make a referral, or in some cases providing pro bono services. Now that the law has changed, inclusion in Medicare allows licensed providers to fully participate. And the way that the law is written, these are individuals who are independently licensed in the state in which they're providing these services. In addition to those changes at the provider level, the Medicare mental health law that went into effect in 2024 also expands workforce and treatment options through provisions that include things like intensive outpatient program services. Those IOP services were not previously a part of the Medicare program, as well as expanded options for mental health crisis response, such as mobile crisis. And these are all things that within state Medicaid programs may or may not already be the state of things. But for Medicare, it had always lagged a little bit behind some of those more progressive Medicaid offerings. And so again, CMS really excited about the opportunity to make these expansions, which again required congressional support to be able to do that. Additionally, we've seen through and beyond the pandemic, expansion of telehealth opportunities for behavioral health services, many of which within Medicare have been written into the statute and are now the new way that services are delivered, and there's not not much interest in going backward on that. Additionally, things like caregiver training services, services and codes related to risk assessment, for social determinants of health, as well as community health integration and principal illness navigation. These are all new codes, new opportunities that really try to bring Medicare more into the 21st century when it comes to sort of holistic understandings of what prompts mental health challenges and how we sustain movement toward treatment along the way. Similarly, some payment adjustments within the Medicare statute around crisis, around substance use, even some modest increases around psychotherapy. And counselors and MFTs were included as eligible providers for health behavior assessment and intervention services, which you see here in the call out on the right-hand side, address psychological, behavioral, emotional, cognitive, and interpersonal factors in treatment. So these HBAI services that counselors and MFTs are eligible to participate in are really intended to expand the way that we think about mental health care and not have such a narrow focus on a particular mental disorder that may qualify somebody for treatment. These are intended to be much more holistic, again, consistent with Dr. Seshimani's quote. So that's a snapshot of what is now available to counselors and MFTs. And I do want to report that provider enrollment in Medicare is off to a great start so far. There may be individual stories where Medicare enrollment has been challenging, so I don't want to discount that. But when you look at this on a macro level, we saw in 2024 alone over 60,000 counselors and MFTs who enrolled as Medicare eligible providers. About roughly 50,000 of that 60 were mental health counselors, with another 11,000 MFTs. And just to put that in context, there are currently 103,000 licensed clinical social workers and 41,000 psychologists who are enrolled as Medicare providers. So when you think about the 35 plus year history of LCSWs and psychologists in Medicare, within just 1 year, the combination of counselors and MFTs has already surpassed 60,000, which is significantly more than the number of psychologists and about 60% of the full number of LCSWs. So this is something to be pretty proud of. It's also, one way to think about this is that just about 18 months ago, we weren't eligible to even participate in Medicare, and now we make up about 30% of the counseling and therapy providers in that massive federal program. And even with that exciting update, there's still room to grow. So there are currently conservative estimates of 235,000 licensed counselors in the US, 81,000 licensed MFTs in the US. And so while that 60,000 number is something to really be excited about, it also represents a long way to go to ensure that Medicare recipients have as many options as possible with as many providers enrolled as possible. And all things considered, then, the Mental Health Access Improvement Act increases the potential mental health specialty providers by an estimated 42%, just by virtue of how many counselors and MFTs there are relative to LCSWs and psychologists. Now, I mentioned earlier that there are actually two Medicares going on when it comes to outpatient services, and Medicare recipients have an option to enroll either in Original Medicare or in Medicare Advantage. And Medicare Advantage enrollment is growing. You see here that we have surpassed the 50% mark for Medicare Advantage, and it has been projected that those figures will continue to grow. The graph on the screen here shows Medicare Advantage enrollment surpassing 60% of that mix by around 2027 and continuing on a steady increase beyond that point. And that does have some implications for how counselors navigate the enrollment process as providers, as well as the services that they may provide. Just to make sure that we're all on the same page, Medicare Part B, otherwise known as Original Medicare, That is the fee-for-service version of Medicare that any counselor or MFT who's independently licensed in the state where they provide services can now enroll in. Medicare Advantage is the outpatient services program that has a private insurance presence. And so you might have a private insurer. Think of your think of the many different workplace private insurance companies that you may be familiar with. Many, if not most of those, have Medicare Advantage plans that they are operating in tandem with CMS. And those private insurance plans then get to make certain decisions about what they cover, what they don't cover, what copays and deductibles look like, et cetera. CMS does set some minimum thresholds for what has to be provided, as well as for the sufficiency of providers for different specialties in a geographic area. But the private insurance company gets to make its own decisions about some of that as well. So it is important to note that this Medicare Advantage presence within Medicare, it's been there since 1997, roughly, but that it does represent a privatization of the Medicare program that's always been, in balance with Medicare Part B, but we are seeing that privatization continue to tick up. And I think that's something to pay attention to as, mental health advocates. Medicare Advantage can offer additional benefits, and so that's part of what can make it attractive right off the bat. However, it may have a higher deductible than Part B. There can be an out-of-pocket limit, which can sometimes be quite high. There may be limited provider networks. So CMS scrutinizes these provider networks every so often, but that doesn't mean that they catch every time that a provider network may not be fully adequate. Some Medicare Advantage procedures may require prior authorization at a rate that exceeds what is required by Medicare Part B. And somewhat ironically, Medicare Advantage costs the federal government 22% more per enrollee compared to Medicare Part B. For mental health providers, one of the biggest takeaways right now, as enrollment is still relatively new for counselors and MFTs, is that there is an enrollment process for Medicare Part B that CMS and Medicare administrative contractors cover. Then there's a separate process to enroll in each independent Medicare Advantage plan. So we've heard from some providers who have enrolled in Part B and then have chosen to enroll in anywhere from one to maybe a dozen different Medicare Advantage plans. And again, this parallels enrollment in private insurance panels. And so if you're already paneled with a private insurance company, there may be certain paperwork that they don't require of you to therefore enroll in their own Medicare Advantage plan, but each insurance company is going to handle that a little bit differently. One of the other key implications is that within the Medicare Advantage plans, there may be a limited number of available spots on their mental health counselor or mental health therapist panel based on geographical location and a network adequacy formula that CMS monitors. And what that means in practice is that we have heard individual cases where providers wanted to enroll in a particular Medicare Advantage plan, went through some of the steps to do so, and then were told by the Medicare Advantage private insurance company, I'm sorry, your enrollment has not been approved. We don't currently need any more counselors in this geographic region. And so that's something to consider. Whereas Medicare Part B, which again is operated much more at the federal CMS level and through these regional contractors, there is not a network adequacy issue there. Anyone can enroll once eligible for Medicare Part B to be a provider, and that does create some different dynamics for what enrollment might look like. So that 60,000 number that I quoted, that represents the number of counselors and MFTs who have enrolled in Medicare Part B. We don't currently have good data on how many of those same professionals have enrolled in Medicare Advantage plans, although I can share a little bit of a snapshot from some data that we've collected from Part B enrollees. And I'll do that here. So nearly half of a sample of enrolled providers that we collected, and we meaning a team from Virginia Tech and the University of Tennessee, Knoxville, um, collected data from 384 individuals that enrolled as Medicare Part B counselors, and nearly half of them reported enrolling or in the process of enrolling in at least one Medicare Advantage plan. So you see here that about 46% had either enrolled or were in the process of enrolling. What's interesting is that 40% of our respondents said, I'm actually not sure, which either indicates that their employer or some other entity that may help them with enrollment was handling that and they weren't sure where they were in the status of that additional enrollment. Or it may indicate that many of these providers who are now Medicare eligible are not totally aware of the need to enroll separately in each independent Medicare Advantage plan. And so there is a degree of provider education that goes into this brand new chapter in the counseling profession's history. Some other key findings from our data: enrolled providers accepted a variety of other insurance types. So very few cases where someone is only enrolled as a Medicare provider. In about 97.7% of cases, they had also enrolled in a private insurance plan, not necessarily Medicare Advantage. These may be non-Medicare plans where an individual is paneled with one of the private insurance companies you see on the screen, as well as Medicare. So maybe they panel with Aetna, Aetna's general insurance plan, as well as Medicare. Another nearly 70% of respondents had enrolled with state-based Medicaid in addition to Medicare. Nearly half had enrolled in TRICARE, and about 20% in the Children's Health Insurance Program. And like I said, a very small number that said, aside from Medicare, I don't take insurance, only 0.8%. So just a handful of cases where that was true. There have been efforts underway to try to understand these new providers coming out of these data that myself and my colleagues are collecting. And so we have embarked on a national survey of Medicare enrolled providers to try to better understand what their experiences have been, what's motivated them to enroll, how it's impacting their caseload, as well as their training and preparation to work with older adults and people with Medicare qualifying disabilities. We're also doing some qualitative interview follow-ups to better understand what it's been like to be a Medicare enrollment early adopter. And you see here the co-principal investigators, Dr. Jordan Westcott at University of Tennessee, Knoxville, and Alexis Isaac from Virginia Tech, graduate student there. Some key takeaways from this research that we have embarked upon. One is that, okay, so when you look at caseload overall, we asked these respondents to tell us about their caseloads and how their caseloads were evolving post-Medicare enrollment. So they told us that about 44 clients were on my caseload 1 year ago, currently have about 42 clients, and I anticipate having about 44.6 clients 1 year from now. So pretty stable in terms of what was happening before Medicare enrollment, which the 1 year ago indicates, compared to anticipated clientele 1 year from now. But when we started to ask them more specifically to break down how many clients they expected to have on their caseload who were over the age of 65 or who had a Medicare qualifying disability, we start to see some more variation. So I want to point out a couple of things here. One is that when we asked people to go back in time by a year prior to Medicare enrollment, about 20% said that they had 0 clients age 65 or older on their caseload. And about 57% said I had between 1 and 5. And maybe they were seeing these individuals through private pay, sliding scale, pro bono, something along those lines because of not being Medicare qualified at that point. When we look at the current snapshot, the number of people with no older adults on their caseload drops markedly down to about 13.6%. And when we ask them to project out 1 year into the future, they expected that number to go down even more to about 9.4%. And so we see this decrease by about half between a year ago and a year into the future. And we see similarly the estimated number of clients between, let's say, 6 and 10 older adult clients jumping from about 10% to about 21.5%. And an estimated 11 to 20 older adult clients, so almost half of a person's caseload, jumping from 7.5% up to 14.7%. So we really do see some shifts happening within age demographics inside these provider caseloads, which makes sense given that this is a brand new population of Medicare recipients that they now have access to. And all things considered, 1 year ago, the average number of older adults on a caseload was 5.6. The current caseload is about 6.6 older adults. And 1 year from now, the estimated was 9.3 older adults. So again, some significant upswing in terms of how many older adults they expect to serve. A couple of takeaways in regard to older adult clients. That's about a 17.6% increase in older adults served between 1 year ago and current, and another 40% anticipated increase between current and 1 year from now. And when we look at that all together, a year ago compared to a year into the future, it's roughly a 65% increase in the number of older adults served, again, going from 5.6 on average to 9.3 on average. We asked these respondents to give us the same sort of information based on people with Medicare qualifying disabilities. And so a year ago, respondents said, about 42% of respondents said that they had 0 clients with Medicare qualifying disabilities. When they looked at their current number, it had dropped to about 35%. And when they projected into the future, it was more like 27.6% that anticipated having 0 clients with Medicare qualifying disabilities. Compare that to the number with 1 to 5 Medicare qualifying disabilities clients, 38% a year ago, increased to 44% currently, and up to almost 49% 1 year from now. The shifts are a little bit more subtle here. So the average number of cases 1 year ago was 6.43. The current number of cases of individuals with Medicare qualifying disabilities, 6.7. And the anticipated 1 year from now, 6.9. So again, there is a trend. It's a little bit more of a limited trend compared to the focus on older adult service, but we do see a 4.4% increase in the number of people with Medicare qualifying disabilities served between 1 year ago and current, another 3.1% anticipated between current and 1 year into the future. And this results in a 7.6% total increase comparing a year ago to 1 year into the future. And again, while that may seem more muted compared to the older adult shifts, it is still indication that enrolling as a Medicare provider, there is an uptick in the number of individuals with Medicare qualifying disabilities who are being served, which is what we would expect by creating more access points through more qualified providers. You would expect the mental health needs of individuals who qualify for Medicare to be met more sufficiently. And so we're starting to see that bear out, at least from these particular Medicare survey respondents. A couple of other takeaways, just to point out, when you look at estimates from a year ago, it suggests that just a hair over 12 recipients, Medicare recipients, were already on mental health counselor caseloads. And this anticipated increase of 3.66 older adults and 0.49 clients with disabilities leading to an average total then of 16, just a hair over 16 Medicare clients. Um, so what I want to impress upon you here is that our counseling professionals were already serving these populations prior to becoming eligible to enroll, which is interesting. There's sort of this perception that we were completely shut out of serving these populations, and now the switch has been flipped, and we're starting to see these clients show up. The reality is that Medicare recipients have been looking for mental health care even when counselors and MFTs were not allowed to be reimbursed for it. And so we imagine that counselors and MFTs were finding other creative ways of providing these services. I mentioned sliding scale, pro bono, private pay as a couple of strategies that may have been employed. But it suggests that these professionals have already had exposure to working with these populations, but now that exposure is much more sustainable, reimbursable, and can be built out in a much more comprehensive manner. And that may look like, just as an example, that may look like shifting from, well, my Medicare recipient is able to pay out of pocket once a month because I can't take their Medicare insurance. Maybe that was the case a year ago, to now, because I can take their Medicare insurance, they'd like to meet weekly and we can really make some more traction on whatever their presenting concerns might be. So those sorts of shifts, that's somewhat speculative. The exact dynamics we don't know, but it was interesting in this data to see that we already had a fairly sizable proportion of caseloads that were comprised of older adults and people with long-term disabilities. And beyond that, when you think about, roughly 4.5 new client cases being added, over the next year to each of these professionals, those numbers really start to increase pretty rapidly when you extrapolate this to 60,000 newly enrolled providers, and that number will continue to grow, to increase in subsequent years. So while we have already been serving these populations, we're certainly seeing that Medicare enrollment is adding more opportunities to serve these folks. And as I mentioned, maybe increasing the sustainability and comprehensiveness of the work that we're able to do with these Medicare recipients. As much as this is all exciting to report, I should say that Medicare advocacy is still ongoing. Now that we have a seat at the table, meaning the Medicare table and all of the moving pieces around healthcare policy and what's happening within CMS, much of which has, drastically shifted even in the past 6 to 8 months as we have a new administration with new decision makers. Now that we have a seat at that table, we are part of a national discourse on entitlement programs, including Medicare, but Medicaid would be a part of the national discourse as well. We have more opportunities to monitor proposed changes to the Medicare program at a broad level, not just what Medicare will do for counselors, but what Medicare is doing writ large for the American healthcare system. We also have a chance to raise awareness of the impact of Medicare changes on the nation's mental health. So our role as healthcare advocates expands markedly now that we are part of the Medicare program. And this also gives us a chance to work collaboratively with other Medicare mental health professions to collectively raise our voices. So whereas in the past, for example, clinical social workers were added to Medicare in 1989, that was a source of some discontentment among many counselors and MFTs because of wanting parity with social work, wanting equitable opportunities compared to social work. Well, we're no longer in that chapter, at least when it comes to Medicare. We're now in a chapter where we are at the same table, and there are many reasons to think about how do we work together as allies across mental health professions, knowing that as mental health professionals, we have a shared, unique perspective on the mental health needs of Medicare recipients that other healthcare professionals within Medicare may not fully appreciate. and Medicare decision makers, even all the way up to the CMS level, may not fully understand. So it shifts some of the dynamics about who we want to collaborate with and how we want to collectively talk about Medicare and mental health access. Additional advocacy considerations, current reimbursement rates are, chronically something that is an area of concern. There are some efforts being made to increase the rate of reimbursement within Medicare. We are currently at 75% of the amount that is paid to a psychologist. That's the same for clinical social work. And there are efforts being made to increase that to 80% across the master's level mental health professions. And so, excuse me, to 85%, as you see in the key next step section of this slide. Additional efforts, ongoing congressional efforts to protect the current physician reimbursement rate. So counselors, social workers, psychologists, all of us are treated as providers whose reimbursement is a derivative of the physician fee schedule. That's a report that comes out every year. There's public comment every single year, and the physician fee schedule rate will be adjusted up or down depending on a variety of factors. We now have direct skin in the game when it comes to that equation, and have to monitor and advocate for increases or maintenance of the physician reimbursement rate, in addition to wanting to shift from a 75% of that rate to 85% of that rate. There's also ongoing need to maintain telehealth flexibilities, implications for counselors. As I mentioned earlier, there's a lot of momentum with telehealth and no overt indications of going back to telehealth being restricted within Medicare, but there are certain elements of how telehealth is currently accessed and authorized that will continue to need maintenance and continue to need legislative advocacy to ensure that Congress acknowledges all of the detailed ways that telehealth needs to look for it to operate smoothly. Last thing I'll say about advocacy is that there is a Medicare Mental Health Workforce Coalition that includes numerous mental health and aging advocacy organizations. The National Association for Social Workers just joined as an additional coalition member. And so again, this represents a chapter in counselor advocacy where it was much, much less about what do we get out of this and much more about how do we work across different disciplinary categories to really advocate for the people that we want to serve. And so shifting our advocacy from what's good for counselors to something much more centered in what's good for our communities, what's good for Medicare recipients, was really one of the paradigm shifts that I think made this Medicare enrollment advocacy successful. I will try to kind of blitz through these last few so we have some time for Q&A as well. But I do want to note that these Medicare changes will impact traditional counseling settings as well as new employment contexts. And that means that as a profession, whereas allied mental health professionals, we have to really think about the training and the paradigms that we have operated in from historically. Over the course of several years, my teams have done some research on this. And again, I'm more of a gerontology aging-focused scholar, but similar cases can be made for disability and have been made for disability. Professionally, we tend to overlook age, we tend to overlook disability, and that shows up in the ways that our students are trained, that our professionals are trained. And so it's really imperative on us as the new kids on the Medicare block to make sure that we are doing our due diligence to become as anti-ageist, anti-ableist as possible in the training and work that we do, and to be aware of the new settings that we now have access to, and some of the innovation that can come from that. One example of this, in Virginia Tech area where I work and live, we have a partnership with a local continuing care retirement community where one of our interns can complete their master's level training in that retirement community context, operating as an integrated care and sort of roving private practice counselor. It's been very successful. It's been very well regarded by the residents of that community. And it's been a great opportunity for our students to begin to connect some dots and see the ways that I have to operate a little bit differently when I'm working across maybe age or across ability status. It's been some good learning for those students. There are many resources out there that are beginning to shed light on the ways that Medicare changes are expanding the context that we can work in. I do want to give a quick shout out for the National Board of Certified Counselors has a webinar series that focuses on many of the enrollment considerations and how to serve different populations and issues based on this newfound Medicare enrollment status. But when it comes to expanding the treatment context that people can now work in, not only is this helpful for agencies and private practices, but this also has many implications for integrated healthcare settings such as federally qualified health centers, rural health clinics, Medicare hospice interdisciplinary work, and any sort of integrated care context that you might think of where Medicare dollars have been a primary source of ongoing reimbursement and revenue. Historically, we had heard cases of counselors being well qualified to work in these integrated care contexts, but being turned down for jobs because they were not Medicare reimbursable. And it sort of made sense in that pre-2024 world. If you are an integrated care context that has a lot of Medicare dollars coming in and out, a lot of Medicare recipients coming in and out, you need professionals who are eligible for the full reimbursement. And counselors were not part of that list, and therefore we were overlooked for some jobs. That will change, that is changing, that will continue to evolve now that we are fully reimbursable. We have more access to some of these integrated care work opportunities. And it'll be interesting to see the way that that impacts our profession and our professional self-identity going forward. The last couple of things I'll note is that if you are a practitioner or a counselor educator or a student, really any status that you occupy professionally, Medicare recipients need the work that you provide. Older adults, and same with people with qualifying disabilities, there is a significant number of these individuals who qualify, who meet the criteria for having mental health disorders and needing clinical treatment of such things. We know that depression, anxiety, these are not normal parts of aging. These are not normal experiences per se among aging or disability, but these are issues that impact a significant number of older adults as well as individuals with Medicare qualifying disabilities. And therefore, the more professionals we have within this Medicare ecosystem, the more opportunities to make sure that there are adequate services, adequate access to mental health care, so that those people who would benefit from these services can do so efficiently and effectively. We know that mental health counseling, rehabilitation counseling, these are incredibly helpful services that allow for treatment to really work. We need access points and we need more providers to be in this system, in this ecosystem, so that Medicare recipients have access to the full range of providers. And I'll move us ahead, just given our time. Counselors have some unique perspectives to offer. In the counselor paradigms that I have been steeped in, we talk a lot about holistic wellness and the multidimensionality of what it means to be human. We think a lot about client strengths and resilience. We think a lot about development and how development shows up differently depending on the different contexts that we occupy. These are all perspectives that counselors can bring to bear on the work that they do with Medicare recipients. Again, the slides here will have a little more of a skew toward older adulthood because of that being my area of research expertise. But we know that counselors have a lot to offer these populations that have historically been not as well represented in our counselor training, in our counselor field experiences. And so we're really eager to look for ways to incorporate more focus on age and disability within counselor training, within counselor preparation, and allowing this Medicare change to drive more conversation, more professional dialogue about that. One of the things that I've been grappling with is that, again, prior to 2024, we had this huge proportion of our population, about 20%, that rely on Medicare, that we had a very difficult time accessing. And that led to not giving them as much of our attention in our training programs. And post 2024, that's no longer the case. And so we can no longer use a lack of Medicare reimbursement as some sort of excuse for overlooking these populations of people. And instead, it's high time to really raise the profile of what are we doing around age and disability. We know that national demographic trends are not slowing down. We've got a higher and higher proportion of older adults in our country. Therefore, we need to really think critically about what we're doing to serve these populations. There are some additional resources here around wellness, around resilience, specific paradigms that I think counselors bring to bear in their work. But the last thing I want to leave you with before we have a few minutes for questions is that the counseling profession, it's really a professional imperative to address ageism and ableism at all levels. This has always been the case. It's always been something that we've at least given lip service to, but we really need to move beyond just talking about this or saying that this is a part of what we want to be. And we really need to move to a place of action and committed action. And again, if the Medicare law change can be one of the drivers for that action, so be it. If it can be one of the reasons why we say, okay, this is the turning point for us, so be it. But talking about ageism and ableism and understanding the ways that these particular challenges continue to permeate our national discourse, they permeate the ways that we think about what it means to be human. And these are important, significant things that we need to have more proactive dialogue about in our counselor training programs. I have some resources here that focus on the rates of ageism, which unfortunately are on the upswing, on the increase. Interestingly enough, two predictors of ageism that have been found. One is when the ratio of older adults to younger adults increases in a society, more ageism follows. The other is that when aging is viewed as a medical problem to be solved and not a normal part of the human experience, ageism tends to increase. These are trends that don't seem to be going away. And so we need to be really clear-eyed about the way that we talk about anti-ageist, anti-ableist approaches to counseling within the work that we're doing. And again, I'm sorry to sort of rush through these last couple of slides here, but I do want to leave a couple of minutes for questions. If you're interested in more about ageism and the impact of ageism on health and well-being, Breaking the Itch Code is an interesting read from Becca Levy. Levy's scholarly work has been incredibly influential in the gerontology world and in the healthcare world more largely. And she makes a really strong case and shows with a lot of data the ways that internalized negative age attitudes really do impact not only our well-being, but they can take up to 7.5 years off of our lifespan. And that is ultimately due to the internalization of ageism, meaning that we become susceptible to this belief that we no longer matter, and that no longer sense of mattering can impact our health behaviors and our will to live. So again, ageism, ableism, these are significant issues that we need to spend more time talking about in our counselor training programs. And with that, I will go ahead and kind of turn things back over. I know we just have a few minutes left, but if there are questions, I would love to spend a couple of minutes doing that. And I'll have my contact information here on the screen as well.
Yeah, I jotted down some of the questions from the chat. So the first one was, do you ever see a CRC being qualified to invoice Medicare, Medicaid in the future? My guess is probably not.
I won't speak to Medicaid specifically, but in terms of Medicare, I think right now, again, that standard of practice, the minimum qualification is the independent license to provide counseling services. That would be the primary route. So I'm not sure what the future holds. You know, anything is possible. I think there are certainly opportunities to try to build out even more of a comprehensive team when it comes to who can be served and who provides services. But that minimum threshold that was just passed into law in the past couple of years does require independent licensure. I know even from working with recent graduates who are counseling residents in my state, there's some frustration about not being able to participate in Medicare as a resident. And so that is one benchmark, that independent licensure that it was really needed to be able to get the legislative change over the finish line.
Thank you. That kind of goes into the next part, speaking about students. Is ageism part of the curriculum in counseling programs?
It's referenced. I could speak to the CACREP standards, the 2024 CACREP standards, which are of course the most recent ones. They do include age and generational status alongside many other kind of social identities in their glossary definition of marginalization, diverse identities. If you think about definitions of how we want to approach living in a multicultural uh, society, age and generational status are there. How that is operationalized in the classroom, I would anticipate you're going to get 1,000 different ways that shows up if you have 1,000 different programs. In my program, we really try to make that front and center within our lifespan development class. And we even just recently piloted splitting our lifespan class into two, having one that focuses exclusively on children and adolescents, and another that focuses exclusively on adults and older adults, as one way to respond to the need for more time to talk about age and disability, and how sometimes that can get overlooked when you're trying to cover so much material in just one course. But it's a great question, and there's a lot of improvement that still is needed to make sure that ageism and ableism are adequately covered in the classroom.
And we just got one last question. What instigated the change in Medicare in 2024? Was it COVID and all the mental health issues that came out of that?
That's a great question. So, since the early 2000s, counseling organizations had been advocating for these changes. And I began my involvement with this in roughly 2010. And I can speak to then over the ensuing decade, a lot of efforts to try to impress upon Congress that this was needed. I do think to the question asker's point, I do think the pandemic opened up greater awareness of the mental health needs of Americans and activated some maybe latent willingness to make changes. But none of that would have been possible without all of the advocacy that was already underway. And so it really became a perfect storm of that advocacy and the relationships within Congress and advocacy organizations, and the pandemic sort of becoming a part of that, changing some of the ways that we were articulating the importance of this, the previous administration having a desire to make mental health care more accessible. All of those different things came together And again, that perfect storm at the end of 2022 where Congress said, yeah, let's make this happen.
Cool. We just got another question, but we're at time. So I don't know if you want to just
Sure, I'm
answer that
happy
or
to. Yeah, happy to.
okay. Um, the last question was, could you speak on the Medicare adult long-term care waivers, wanting to learn more about counseling within this population?
Sure. So specifically, long-term care occupants, if I'm understanding correctly, within individuals occupying long-term care facilities, that would be one. Or I'm not sure if they're talking about home and community-based services and waiver programs that keep people at home and receiving services in home. But in either case, what I can say is that there are a lot of Medicaid sponsored programs that either show up within long-term care settings or within HCBS services. And so there may be some need to navigate both Medicaid eligibility as a counselor and Medicare eligibility as a counselor. When those programs layer on top of each other for individuals that qualify for both, those are referred to as dual eligible populations. Sometimes the regulations and how they sort of interface with each other can be complex. And so I think each state is going to navigate that a little bit differently. And we're also in a macro political climate where there's a lot of things shifting around when it comes to Medicaid and Medicare. So I don't have a lot of really specific recommendations for how to navigate that. But I do think that this Medicare law change opens up that category for counselors who meet the criteria. And that's essential because we know that those are some of the same individual clients who have unmet mental health needs. And so being able to participate in that is really important.
Great. So that was the end. We'd like to provide our sincerest gratitude to you, Dr. Fullen, for this wonderful and meaningful presentation on Medicare and the counseling profession. We're very grateful for you taking the time to share with us today. And for those in attendance, we appreciate you joining us, and we'd love to invite you to the save the date for our next ARCA webinar, which is scheduled for September 19th at the same time.